Thank you, Terry. Can folks hear me?
Me and my children had asthma.
Oops. Thanks, Terry, for inviting us. We're really pleased to be here, particularly leaving Boston and getting to the balmy, sunny 40-degree temperatures of Washington, D.C. We have 3.5 feet of snow on the ground with more inches today and another foot forecast for Monday. So we're happy to be here. I think the football gods allowed the Patriots to win the Super Bowl, but the weather gods are punishing us for it. So what we're going to do is we're going to talk a little bit about what we've been doing in Boston. I'm going to talk more specifically about the community asthma initiative that we've been launching at Boston Children's, and then Margaret's going to talk a little bit more about the sort of environmental healthy homes component and the home visiting collaborative that we've established. But we're going to start with a video, and hopefully that'll get everyone's attention.
We were restrained to different activities and a different lifestyle, and by them growing up, they couldn't swim and go to recreational activities because I was scared every time they turned around they had an asthma attack. I wanted them to be able to interact with other kids and to do vigorous, fast activities. Now my daughter, she's in soccer. She's in after school care, something that I didn't think that she was going to be able to do about a year ago. And my son, I got him a scooter, he got a bike, he has a basketball, we play basketball. I let him run around on the scooter, I let him run around in the park, things that he was not able to do.
My name is Natalie Bazil, and I work for the Boston Public Health Commission. I work with the Boston Asthma Home Visit Collaborative Program. The service that I provide is for all Boston residents who suffers with asthma. I provide 3 separate visits, and they're all free. I sit down with the family, hopefully they have an asthma action plan, review the medication with them, and it's a time for them to share any of their concerns about the medication. Some of the important thing is walking through the home, doing an assessment. A lot of times there are triggers in the home that family don't even know that's affecting the asthmatic in the home, such as cleaning products, dust, pests in the home. So these are some of the things I cover. In addition to that, I do provide some free supplies to the family, such as dust mite covering, vacuum cleaners. The home visit is really a wraparound service where the goal is to have everybody to have a normal life. The asthmatic could go to school, play, swim, do anything that a normal child could do or a working person can do. And for the caregiver of that individual, for them to A, go to work, B, go to school, just have a normal life.
Anybody that I know that has asthma, I pass off the number because it's life-changing. You know, it's like, who would have thought that I can walk around the block now without panting? It changed me. I'm going to Zumba now, something that I could not do because of the asthma restriction. Just that one little step, that one little phone call made such an impact on our life that will last forever.
So that's a video that Margaret and her group produced, and we'll be talking a little bit more about that in a minute. I'm going to start off by talking a bit about the Community Asthma Initiative that was launched at Children's Hospital about 9 years ago now. Really to try and go into what it is that we, what the reasons were that we started it, where we've gone since then. So we really started off with assessing the needs, and just like the last presentation, we've actually been really doing needs assessments for a while. My role at Children's is that I'm a pediatrician, but I also oversee our Office of Community Health, which is the community, part of the community benefits mission of the hospital. So I'm in a sort of fairly unique position. But we do community needs assessment, and asthma has been still is actually the leading single diagnosis for hospitalization of Boston children. Can you hear me now? Is that better? Okay. So it is the leading single diagnosis for children at Children's Hospital. It's something that when we actually looked at the data, 70% of the children who were hospitalized came from a specific set of neighborhoods, 6 particular zip codes within the city of Boston. And they were predominantly poor African American and Latino neighborhoods. In addition, folks may not be aware, but New England obviously has the highest prevalence rate of asthma in the country. And within our schools, we have quite a range, but some schools as high as 24% of the patient population that has, the school population that has asthma, with an average of around 15 or 16%. So that's pretty significant. And so this is one of the reasons why we really wanted to focus on this as an issue area, and particularly because of the disparity with hospitalization rates for African American and Latino children being 4 to 5 times higher than the rate for white children, although the prevalence is not 4 to 5 times higher. There is a higher prevalence. It's it's about 2 times higher, but the hospitalization rate is 4 to 5 times higher, which indicates an issue around asthma control. And so that was really the stimulus for us to start this particular program. What the program provides, the Community Asthma Initiative was started to really try and get into the home, to provide better asthma education, to provide case management, to utilize community health workers who could go into the home, assess the environment, and really work on environmental remediation, medication adherence, and addressing some of the other potential issues such as access to medications, housing, any potential legal issues as well. I think one of the things that's really important is that we try and establish what the family's goals are for asthma control. One of the challenges that sometimes families don't realize that their child can actually go through an entire day and not wheeze. And so they think that a child's doing well. They're using their inhaler 3 times a day, but they're not going to the emergency room and not going to the hospital, so that's good. They think that's as good as it gets. And so part of what we want to try and do is make sure we're educating people to understand what asthma control is and what children should be able to do while when they have good asthma control. So that's really one of the key things that the community health worker really works with the families on. In terms of some of the environmental issues, we do environmental remediation, provide vacuums, so every family gets a vacuum cleaner. They're $80 to $90, cheaper than a month's worth of flow vent for control of asthma. And bedding encasements for protection from dust mites and other allergens. We work closely with the Commission in terms of inspectional services. Margaret will tell you more about the Breathe Easy at Home program. And then referrals as needed to specific other resources in the community, whether it's child care, job resources, legal resources if that's needed as well. We have a medical legal partnership program based at Boston Medical Center and at Children's that we can use in addition. In terms of our experience with the program, and this is in your packets, there's an article from Pediatrics that has these graphs in it. So we've been able to see significant 57% decrease in emergency room visits, 80% decrease in any admissions at 12 months. So the green bar is the baseline, the blue bar is the 6-month, and then the green bar is the aqua bar, I guess, is the 12-month. So over this period of time now, we've been doing it for 8 years. We've got 8 years worth of data, so the numbers over 1,200 at this point. And very consistently with each cohort, we continue to see that, that decrease. Similarly, when we look at missed school days and missed work days due to asthma, seeing, again, a pretty significant decrease of between 40 and 50% for school and work days for parents over this time period. And asthma is actually the leading cause of absenteeism from Boston Public Schools. In terms of costs, the graphs on the my right, the blue ones, show costs for the program. We're identifying a pretty high-risk patient population, so starting off somewhere around $3,000 for the cost of asthma services for children in the year prior to them going into the Community Asthma Initiative. A year later, down to $1,300, and 2 years, $750. We did, after a while, use a comparison population to try and really solidify this and make sure it was not just regression to the mean, and showing, again, that there is some decrease over the same time period for a comparison population. The green is a Dorchester neighborhood, which did not get the community asthma intervention initially. They are now. Again, not quite as sick a population, so not starting off as high, but showing more significant, again, the significance of the decrease for our population. In terms of where we're trying to go with this, we have been working with others in the region. In addition to the Boston Public Health Commission, there are the New England Asthma Regional Council and Health Resources in Action have been working on a more regionalized approach to asthma. They have a CMMI grant that's actually looking at home visiting and case management across several states and in several locations within Massachusetts that we're participating in. We have a manual that we've developed that's a replication manual for others, going through what some of the things were that were useful for getting the program started, what kinds of partnerships we needed to build, and what kind of data we tracked. We are now really thinking about how to truly make this population health, in the sense that the program, when it started, we identified children by looking at emergency room visit logs and hospitalizations. And so that's where that's the index point. That's the point where the child and the family enter the program. And as I said, with that as the index point, have been able to show these decreases. But we really do still need to move upstream. So we need to move to the primary care setting to provide better asthma management and education and control so that that very first hospitalization or that very first emergency room visit is prevented. So we're in the process right now of working with our community health centers and practices within the city. Boston's fairly unique in that there are 23 community health centers just within the city limits, and 50 to 60% of the children in Boston receive their care in community health centers. We also at Boston Children's have a very large primary care practice, and probably between we have one practice on site, we have an adolescent clinic and a smaller community site. And between those, we have about 15% of the children in Boston that we provide primary care to. So there's an opportunity to really engage with those groups to really change the management of asthma up front, utilize what we've learned from this case management approach, and engage in community health workers for those practice and the referral system in place so that those families can get the same service and we can actually show a larger impact than we currently have at this point. The other piece that I'll mention before turning over to Margaret is that we've really, from the beginning, started to think about payment for this. Right now, this is supported through community benefit dollars from the hospital, some grants. We did have a CDC REACH grant about 5 years ago that supported part of this. We get some philanthropic support from our Children's Hospital Development Group. And at the beginning, we were really thinking about how do we work with insurers to get coverage of these services. We actually worked very closely with our government relations team to try and work with our state legislature to mandate insurance coverage for these asthma services, and that didn't work. But one of the things that happened because of that advocacy is that when the state legislature was finalizing its budget back in 2011, managed to get them to put in a mandate for Medicaid to do a pilot of an asthma bundle payment for pediatric asthma. It's taken a little while for it to actually get launched, but just starting last month, there are now 3 sites in the state that are doing an asthma bundle payment. There will be a per member per month payment to the primary care practice to cover costs of high-risk asthma patients that have been jointly identified. Those patients, there are a large number of parameters that will be checked. It's still, the payment will not cover the cost of the service we're providing, but I think it's a beginning of trying to figure out what the model is, what's the data that we need to track, how are we going to show that this has impact for the long run. So I think that was I have a picture of the Family Advisory Board. So one of the things I didn't mention is that we do obviously want to make sure we are engaged with the community, and we have a Family Advisory Board and a Community Advisory Board. engaging all of those who are participating in asthma. They meet 3 times a year. The parents tell us what's working and what's not. And we also do, in addition to the specific patient-directed community asthma initiative, we do educational workshops in the community. We work with the Boston Public Schools. We do education sessions for the school nurses. So there's a definite larger, more universal community education component that goes along with the individual approach for asthma. So with that, I'll turn it over to Margaret.